once again. Thanks for coming out, whether it's the late afternoon or the evening for you. We really appreciate it. We're super excited to talk about the world of the clinical med student. We have Lisa Jacobs here, who's one of our faculty advisors. She'll introduce herself, but it's a real privilege for us to work with her and for us to have her here tonight. We'll do some quick intros. I'll go first. I'm the creative director here. My name's Ben. I graduated from med school back in 2018. I did some urology, a year of urology residency at UCLA, and realized that I would rather make cartoons than place Foleys. Since we're talking about clinical rotations, we're each going to share our craziest rotation story. Mine, very briefly, is I was on a trauma surgery rotation, had a trauma come into the ED after a car crash. He coded in the CT scanner. We tried to resuscitate him, couldn't do it. Ended up doing a thoracotomy, so cracked his chest open in the ED, which is a pretty rare and wild event. It's one of those situations where, like, the chief resident was beating his heart with his hand. The chief had to sew up a laceration, and he was so nervous that his hand was shaking with the instruments, and so he couldn't, like, push the needle through and then grab it to pull it outside, to grab a forceps and grab the needle and hand it back to him, which is totally not standard practice. That is one of those events that will stick with me. So yeah, Lisa, we'd love to.
Awesome. That one is certainly crazier than my story, but and a absolute, like, number one reason why I didn't go into surgery. So I am on the academic advisory board at Sketchy, which is relatively new, and I'm a pediatric hospitalist. So I'm the pediatrics kind of specialist on the advisory board. I come from a background of medical education, so I'm an associate program director at the pediatrics residency program here at Cottage in beautiful Santa Barbara, if anyone ever wants to come visit here. I was an APD at UCLA before that, which is where I did my residency, and I was a chief resident there. So, I mean, I said craziest rotation story, but it's probably mostly just like my most memorable, and I don't know. It's a good rotation story, and it reminded me just recently of 4th of July, because it was when I was a third-year med student on my pediatrics clinical, like, ward rotation, and I was on a night shift with my team over 4th of July. And as you guys all, I'm sure, know, 4th of July can come with a lot of crazy injuries that come through the ED, but really I remember it more for, like, just feeling like a part of our team. We all brought, like, potluck dinner stuff in. We, like, managed to run over to the, like, roof of the parking garage and watch some fireworks and, like, run back and take care of kids in the ER. So it's just, like, a really memorable night. It's not as crazy as pumping someone's heart in the CT scanner, but it was quite memorable for me, just feeling like a part of the team, even as a third year, which was pretty cool.
What a classic, the ex-surgeon talks about, ED thoracotomy, and the pediatrician's like, I had a really nice night with my team. We got to see fireworks. And
they loved my team.
Yeah.
Exactly.
Amazing. So unfortunately, Connor can't join us tonight. He had a family emergency. He is an absolute rock star and recorded a video for us that we'll watch to talk about sort of his experience with rotations. He's an M4 at UC Irvine, and he's going into emergency medicine. So we'll hear from him in a little bit. Is the screen showing up funny for everyone or just for me?
It's looking funny to me.
There we go. So yeah, we'll quickly go through this agenda, and then we'll get into it. First, we'll hear from Lisa. I think she has as an associate program director and sort of seeing things from the other side of that sort of residency dividing line. I think she has a lot of experience with what helps a med student transition from being that sort of, like, learner, entry-level clinician into being a really good doctor. So we'll hear from her about that. I'll go through our brand new clinical content and sort of the brand new Sketchy. And then, like I said, we'll hear from Connor in a slightly more virtual way than normal. We have time scheduled for Q&A at the end. By all means, feel free to throw questions in the chat as we go. We'll try to answer them along the way or get to them at the end. There's also a Q&A feature in Zoom, so feel free to make use of that as well. And then we have a very special offer at the end. So make sure you fill out the poll to be part of that. So without further ado, let's hear from Lisa.
Awesome. Thanks, Ben. And I'm not quite as IT savvy as I think some others are here. So I will try to keep an eye on the chat while I'm chatting and talking. But if I miss your question, I'm happy to come back to it a little later on. But just to give you a little more background about me, so I grew up in the Bay Area. That top right picture is Lake Tahoe. I don't know if anybody recognizes that, but it is certainly a place that I grew up going to. We're actually just headed there in a few weeks with my family again. And then down below that is, how I experienced college, which I'm sure many of you experience college by seeing the inside of the library most of the time. And then after undergrad, I, from the Bay Area, came down to Southern California, and then I met my husband here and have stayed here since. So I was at UC Irvine for medical school, and then have been at UCLA, and of course now at Cottage. I put up this picture of me and this little baby who was one of my first and very much most memorable patients. That was like literally my first week of intern year on the wards. And it was just like a nice memory that this is something where you really bond and really have these like deep, meaningful experiences and meaningful relationships with your patients and their families. Like this family asked to take a picture of me and their kid to have at home. Like, it's just something that it's a reminder that like you're doing this all for a reason, and this is the reason. I am not at all biased towards pediatrics, but I think especially so in pediatrics. And then speaking of kids, my own kids are there in that middle picture, which I thought was just a nice example of how my Mother's Day goes in medicine. That this is my husband brought my kids to me at the hospital for a little hangout on Mother's Day. So that's kind of my context of how I kind of came into medicine. We can go to our next slide on here. So I put up these two pictures that I know are like totally corny pictures, but I just feel like it's a nice contrast of how some people like envision how their experience might be in medicine, and then really what it should be and can feel like. It feels very hierarchical sometimes in medicine, where you're like ranked 1, 2, 3, 4 in your med school years, and then you're back down to an intern, and then you're continuing on this kind of like this path that all of us have been on for a very long time. And as a med student, like, right, you're at the bottom. When I Googled to look at these images, like the med student's at the bottom, right? That's just how it comes up. And it really doesn't need to and shouldn't feel like that. Like when you're on a team that is meaningful, you should all have a different role. You all really do bring the corny piece of the puzzle into this mix. So I just want you guys to remember to have that mindset as you're going in. I have worked with every level of trainee on here, even below this, like, shadowing high school students who are interested in medicine. I've worked with every year of med student. I've worked with all the residents. I've even worked with hospitalist fellows who've been, I've been precepting. And it is not that one is any better than the other. It is just different. You are bringing something different to the team. And I think that in working with all these trainees, I've had kind of a nice view of what makes you valuable. So I think that's what I'm trying to bring to you guys tonight, and just to Sketchy in general, to really kind of highlight like where those kind of clinical pearls come in, and where those like moments where you might be considered a more valuable member of your team, like how to get there. Okay, so we can go to the next slide on here. I say what to expect on peds. I know this is not like pediatric specific. Obviously, I am pediatric specific, but it's more just a reminder to approach all of your rotations with an open mind. When I came onto peds, I was like, awesome, we're going to get to play with babies. Like, they're going to be so cute, all this. And the level of intensity that came with peds was something that I did not expect and was pretty surprised by. And it comes in so many forms, right? Like the emotional intensity that can come with pediatrics, and just the workload sometimes I felt like was a little more unexpected when you're like, oh, look at all these cute kids. So I say that for peds, but it applies to every rotation. So if you come in with like a really specific expectation or, set of standards, you're going to be disappointed no matter what. So I just want you to approach coming into all of your rotations with an open mind and just that kind of curiosity. And, sometimes pediatrics is this cute and adorable and amazing. So, so yeah, that kind of takes me to like a couple tips on how to be a valuable member of your team, a successful med student, and how to get the most out of your rotation. So I will, kind of pause and give some additional time to this slide because I do think if you remember nothing else, this would be a good one to just remember your approach to being a med student. You should, if everything else fails, just be curious about what's going on. Be curious about your patients, be curious about how the team operates, be curious about how that specialist knew that and how they knew when to call that specialist. There's so much to be gained from every patient and every interaction that you really shouldn't ever feel bored. And if you feel bored, I promise you, we can sense it. And that I think is one of the hardest things is like, even when you feel like, oh, I have the least active patient on my team's list, or I have the boring patient on my team's list. Like if you feel that way, we feel that, and that's nobody's going to want to engage you on the team. So I would just really push to find that something in every patient. And whether that means like when you are on rounds and it's not even your patient that's being presented, like somebody else is presenting a patient, like have curiosity about that patient too, right? And it may not be the right time during rounds, but maybe it's like afterwards, you're talking to the intern or the senior, like, hey, how did you guys actually land on that diagnosis? Oh, like it was the chest x-ray. Like, okay, maybe I'm going to call the radiology reading room and like have them talk me through how they figured that out. Like just be proactive, be curious, and you will like, the more engaged you are, the more your team will want to engage you, right? They're going to want to bring you into more. So again, this one, if you remember nothing else, just please be curious. You're never going to like, not everybody goes into pediatrics, not everybody goes into surgery, but like there's still something to be gained from every experience.
Since Connor's not here, I just want to add maybe the sort of med student side of this, which is you can't sort of control who your attending is or how they're feeling that day or who your resident is or how they're feeling that day. But this is where you sort of have control and where you can express that genuine interest and that sort of care and investment and engagement. Like Lisa said, if you're not going into peds, if you're going into surgery, there's still a connection, right? Surgeons operate on children. If you're going into psych, there's always a connection you can make if you know you're not going into the specialty to maintain that sort of level of interest and curiosity and engagement. So 100% agree.
For sure. Okay, go on to our next tip is about time. I know probably none of you feel like you have a luxury of time. Nobody ever does. But when you're on a team, especially for me, I come from the wards, and being on the wards when you're like brand new intern or your new senior or trying to get their footing, and they're very overwhelmed by the amount of tasks and the amount of patients that they have. You inherently will be carrying less patients, appropriately so. And that does sometimes give you this gift of time. So with that time, being very, very careful in how you use it can really go a long way to benefit you and your team. So, some specific examples, I always say, like, when you're on the wards, you're going to be pre-rounding on your patients, right? So you're going to see them in the morning, you guys are going to round on them, maybe see them while you're rounding, that you should always, always be able to see your patient again in the afternoon. Your intern and your senior may not be able to do that. And you being able to go and like, whether it's, when it's like a cute kid, it's more fun. You can go and like play a game with them or something. Even sometimes sometimes history comes out during those moments, right? Where like additional history of the case that like you're trying to figure out, it like naturally starts coming through during those moments, which can be super valuable to your team. Other things you can do with your time is just like touching base with your patients and saying, hey, you anticipate them getting discharged in the next few days. Can you like go through their medications with them? Make sure you know which pharmacy they're going to, all of that. Like these little things make you so valuable to your team and are like really are parts of medicine that you have to know and learn anyways. So I would certainly say that like some of the most valuable and engaged med students are the ones who have come to me saying like, oh yeah, when I saw them, like again, whatever, at 3:00, they told me actually like they haven't been using their inhaler like they're supposed to. And so those things that come out really can be valuable. So again, there's a million things you can do with those moments, but definitely engaging with your patient is a big one. So that kind of brings me to talk to your patient, which sounds so silly. And I know, of course, in pediatrics, it's talk to the kid. The kid is the patient. But again, this can relate to any any rotation at all. It sounds silly, but sometimes you don't do that, right? It's the autistic nonverbal child. It's the geriatric patient who is maybe has dementia and is not connecting with you. To walk into a room and be able to make eye contact with that person or that kid and engage a little bit really goes so far, just with you looking like a human, right? Your patients are humans too, and making that kind of human connection goes so far for the families and the caregivers that surround those people. So again, just showing interest in the patient really can go a long way. And I know that sounds so simple, but it can be overlooked in so many situations. Which then brings me to the next slide is also talk to the parent. So you want to talk to your patient, but you also very much, and of course, it's not always a parent, it's a caregiver, it's a aunt, uncle, whoever it is, being able to engage with both the patient and that caregiver is an art that takes time, but you need to start practicing early. And that's something that will go a long way with your team and with the patients themselves. Just making sure those voices are heard, right? And that's again where, like, if you engage with those people, sometimes you're like the superstar who comes back and is like, oh, actually, like, they just traveled to El Salvador and were playing with turtles. And you're like, okay, well, now we have to add salmonella to our list of like why you have fever of unknown origin, right? So those moments really, really do come up organically when you're able to talk to them. And yeah, the one other tiny tip is that always identify who's in the room. I think that's like a really specific one, that you don't want to assume something and then you say, oh yeah, and like, oh, mom over there. No, you never want to assume that. I always, my two lines are either like, if it's an old enough kid, I say, oh, who's here with you in the room? Or if it's not, then I say, oh, how are you related to the patient, before I say anything else. So just engaging with your patients and their family members. Which brings me to the last people that you should be making your best friend when you are on the wards, and in various other contexts. But the ancillary staff members have so much to offer you. And they also sometimes have a little bit more time than your senior or your intern who may be running around. So the bedside nurse, the respiratory therapist, dietitian, social worker, case manager. Of course, in pediatrics, we also have child life. Those people have so much to offer you and really will kind of solidify your role as being your patient's primary doctor if you can connect with those people. So certainly for the bedside nurse, when you're on wards, like right after the nurse has their sign out time, do not interrupt them during sign out time. Then you will not be their best friend. But 7 to 7:30 protected. Do not come to contact them. After that, hi, I'm the med student. I'm taking care of this patient today. Here is my contact information. This is the intern I'm working with. Please let me know if anything comes up. Then that means you're the first person who hears this patient had a new fever. You're the first person to hear this patient is having some trouble breathing, right? And you being able to feel that autonomy and sense of ownership over your patient will come directly from that. The respiratory therapist, hey, can you call me next time you go to give a breathing treatment to this kid? And then they can walk you through, like, what are they hearing? Did the kid respond or not? How did you know they responded or not? Right? Which brings you back to like the intellectual curiosity. So these staff members are awesome. They really will be your best friend. And if you don't engage with them or don't show some like being proactive with them, it can very much work in the opposite direction. So, I'll leave you guys with that. I'm happy to, I know I see some of the questions coming through, which I can try to address. But again, please just approach your rotations with an open mind and with that intellectual curiosity. And for sure, if you just do that, you will be a welcomed and valuable member of your team. And you're also going to get the most out of that learning experience. So yeah, I'm happy to take any questions. And I know we have a Q&A coming up at the end, but that's where I'll leave you.
Thank you, Lisa, for that. That was awesome. I actually thought we could maybe just answer a couple of these questions live. Sure. since we've got them here. So first one is, I think you talked about this a bit, but why did you choose pediatrics as a career? And then in particular, and I'm sure there are other people that have this question, what's a pro tip to match into pediatrics for an IMG? And maybe if you can sort of broaden that to just sort of your experience working with IMGs making that transition to a US residency.
Yeah, for sure. Great question with the IMGs. I'll tell you just briefly for pediatrics, I thought I didn't make the decision to go into medicine until pretty much the end of college. So I took about 3 years off, continuing to do some of my prereqs and stuff. So I had a little bit of an atypical course, but I thought I was going to be a teacher. And then I was able to kind of shadow in clinics and really realize that there's so much teaching that's inherent within medicine, and that being able to connect with patients, especially kids. I mean, I also just like have a soft spot for kids, but kind of putting those two things together is really where I found kind of my love of peds. And then I debated doing Peds hospitalist first PICU because I really did like the acute care setting. But then I kind of just chose my family and lifestyle and decided I wanted to just be done with training. So I was done after that. So for the IMG question, it's a very good question. I'm not sure how many of you know about kind of the IMG match data specifically within pediatrics this year, but our match data overall has gone down quite a bit. So we've just had less people applying into pediatrics, which, just hurts my pediatric heart. But we're working on that from an advocacy standpoint. But that being said, certainly more IMG like applicants are being considered. I know specifically from the pediatric side because of that. In IMG, I think it's really important. I read a ton of applications and I read a lot of IMG applications, and things that stick out to me are really our clinical experiences. So when it's, it's a medical school that has a totally different system than ours here, it can be a little bit hard to decipher what type of actual clinical on the ground experience you have had. So I would say being able to stress that somewhere in your application, whether it's through your letters of recommendation, like really guiding those letters to say, hey, can you please mention how I was on my whatever surgery or pediatrics rotations on the clinical side, because we really want to see that. And then, of course, all the other extracurriculars that you guys have all been doing along the road. I think that's just icing on the cake too. But yeah, I do understand the IMG thing is a challenge for sure.
Benjamin, great name by the way, asks, how do you balance the responsibility of the student to engage and initiate versus the resident or attending's responsibility to educate?
That's a great question. That is an ever-changing answer, even probably day to day, in terms of who you are working with and how busy your team is. So I do think there is some inherent role within yourself that you should be proactive and, like I said, just being intellectually curious. But you're totally right that your team does have a responsibility to teach. And so I think that every person has a different style. So every resident will have a different style of doing that. Every attending will have a different style of doing that. But I think you being vocal up front and saying like, hey, I have whatever, if it's maybe you just like haven't seen one type of patient yet, and you're like, hey, I really haven't seen an asthmatic yet. Can you please like kind of keep a lookout for me? It really engages your team to then want to push more and engage you. So it does meet somewhere in the middle, that like you being proactive and their responsibility to teach you, but just knowing that every human being is different, they're going to have a different level of that kind of push. So I would say that, it's an ever-changing balance, but you do have to kind of meet in the middle.
Yeah, maybe to echo what I said before as well. It can be frustrating when you feel like your team isn't giving you that, when you're paying tens of thousands of dollars a year to be there. But ultimately, all you have control over is how you approach the problem. And so, like Lisa said, being engaged, being curious, those are things that you can control.
For sure.
Let's jump over to the Q&A thing really quick. This is here's a tough one. It kind of pertains to something you mentioned before. Someone with who's graduating with $400,000 in debt, interested in peds, but worried about the lower peds overall.
Well, these are things I wish we could change like yesterday, but do know that from the advocacy side, we really are, as faculty and attendings, going to the level, like legislative level, to work on pay in pediatrics, because as you guys know, and as this question alludes to, that the pay is poor in peds. I would say if they're, in terms of being just a non-traditional applicant, I I see so many non-traditional applicants. I can tell you we took two non-traditional applicants this year who just stand out in other ways. And I think that being a non-traditional applicant is not a bad thing at all. I think that like having more life experience and having some kind of something to add in that sense and make your application really robust, I think is sometimes super interesting to us, and we would love to have you. And then, with the debt and the financial side, it's somewhat of a personal decision, but there are plenty of career paths within pediatrics that do have a higher pay. And it's, some of the subspecialties, being in private practice as an outpatient pediatrician actually pays quite well. So there are, if that's a factor for you, there are ways within peds to do that.
Maybe let's do one more, and then hopefully we can answer some of the others as we go along. Just because you mentioned this before, you said go back and see your patients in the afternoon, and if they're not using their inhaler properly or something, what's sort of the responsibility of the med student to educate them then versus discuss with the team and then go back? How do you know how much of an expert you're allowed to be?
Totally. That's also an ever-changing line, right? Like your first day of your first rotation, you probably are just collecting information and bringing it to your team, which is also super valuable, right? If you just all from that interaction is that, oh, the inhaler is this dose and they're taking this many puffs, that's okay. You take it to your team and they're like, oh, that's not right. And then you go from there. Whereas maybe a couple months into you're like third, fourth year, you may have more to offer, right? So it's that fine line of being confident and comfortable, but not overstepping your own knowledge. I wouldn't say it's like overstepping the team. It's more that you have to be confident in your medical knowledge. And you would never want to overstep that if it was going to affect patient safety. So, in this example, I think if you really had totally had a comfort level with how to use an inhaler and the dose that they're supposed to be taking, of course, it's great to be able to educate. And your team will be thankful that you educated. It's just that if you have any question in your mind that you're not totally sure, just saying, I don't know is the best thing you can do. And just saying, I'm going to talk to my team and I'm going to come back and I'm going to educate you then. And then, I would just say setting expectations with your team in the beginning where you're like talking to your intern and your senior at the beginning of the rotation. Like if they have a very strict policy, they don't want you seeing a patient without them ever, like that would be totally insane. But if that were the case, then that should be voiced, right? So just setting those type of expectations with each new resident you work with, each new attending. And I know it can be hard because these are all every team is a revolving door of people. And you'll see they're swapping in and out a lot. So you may have to have that conversation a lot.
Yeah, I think one of the sort of underrated toughest things about third year is that process of gaining the trust of and getting to know a new team every 6 to 8 weeks, and sort of as you go through the year, you'll become more confident in your clinical skills and the way you approach patients. But, every time you start a new rotation, you're kind of starting from zero with that particular team. And it's tough. The flip side, the nice flip side, at least for me, was you get to, try something new every few weeks. So, but yeah, I think, like Lisa said, you got to read the team and gain their trust before you start opening your mouth. Cool. I know there are more questions. I want to make sure that we have time to get through some of the other stuff. So we'll either save them for the end or we can sort of type answers as we go. But I think for now, let's move on a little bit. I want to talk about the new Sketchy. And in particular, for the folks here tonight, this is a Sketchy really built with the intention of doing a better job of serving students who are on the wards, who are in their, we call it third year, but maybe you're a second year actually when you're a clinical student, but who are engaging in patient care for most of their time. We think that's a format that is, we think that's an experience that's better suited to a shorter, more digestible format, something that you can consume while your resident's in the bathroom or they're finishing up notes or something like that, where you have these sort of little interstitial moments that you'd like to be able to fill with some studying, not the giant blocks of library time that you had in your preclinical years. So, we've heard for a long time that some of our clinical videos are a little bit long, shall we say, euphemistically. And so we've worked on that. We have we've shortened our videos, but we didn't want to just delete or jettison information. There's still a ton to learn. And so we've added some text-based cards. We still want to keep that sketchy magic. And so they have symbols that tie back to the videos or are recurring symbols that you'll know having used Sketchy before. We wanted to put this all together in a package that's easy for you to use, pick up and put down, in the sort of life of a clinical student. The quiz questions that if you've been using Sketchy for the last year or so, you've seen that we've been adding quiz questions to a lot of our lessons. That's sort of pervasive now. And then we finally actually have a real, honest to God, iOS app coming this summer. And when I say coming this summer, like I actually have it on my phone. It's just we're waiting for sort of Apple's final sign off. So this is a real thing that will be coming to your pocket in the wards later this summer. It's not just sort of this revised experience. For a long time, we've had a few of the clinical clerkships covered, but not all of them. And so the release that we did a couple of weeks ago rounds that out. So we've got all 7 required clinical clerkships covered, rotations, perhaps you call them. So that's about 250 new or substantially revised lessons. Of course, there's always all the preclinical, the micro, and the farm, et cetera. And then as part of this too, we've added some what we're calling unit tests that are more scenario-based. They're slightly longer questions than those lesson quiz questions that you've been using. Right now, those are just in micro, farm, and path. We'd love to hear from you about your experience with those. And frankly, if you've had the opportunity already to use those, I would love to hear from you about them. So, a picture is worth 1,000 words, or a demo is worth 1,000,000 or something like that. So let me take over the screen share here, and I will walk you through a little bit of this new clinical experience. It looks a little different. Change is hard, we know. But all the stuff that you know and love is still here. There's just some goodness as well. So one thing you'll see right off the bat is we have all these new, clinical courses, internal medicine, surgery, and Peds we had about half of before, and OB-GYN were done before, but just to walk through some of the new ones, we have a psychiatry course now. We have a family medicine course now, and I think this one is, this one's really interesting because we do this in part as a chief complaint focused approach to family medicine. So rather than a specific disease process, a patient presents to clinic with one of these chief complaints. How do you approach them? What do you do? What are the questions you ask? How do you work them up? We do a lot in these lessons to help you get in a clinical thinking mindset, hopefully. But since Lisa's here, I want to walk through a Peds lesson specifically. You'll see there she is. We're trying to make Lisa famous. She gives this little intro to the Peds course. I'm glad you put that slide with the rainbow and the unicorn on it, because I think you say that exact phrase in the video. So here in Peds primary care, just to pick a lesson at random. This is our lesson on normal developmental milestones. If you're like me, this was always a pain in the ass to remember. We split this into 2, so it's the first year, which is a little more granular, and then 2 through 5, where the divisions get a little bigger. Let me just really quickly do this. Right. I won't play this whole video, but All
right, let's get started. In the first photo, in this lesson, we're going to discuss the normal developmental milestones through the first 12 months of life. And we thought it would be fun to do that by going through a photo album of baby's first year when they're so cute.
So first of all, that narrator sounds incredible. And second of all, you'll see this is the sort of normal sketchy video style, right? We're taking you through symbols. We're building the memory palace that you can then walk through again. You've got the same symbol explorer. If you've been using Sketchy for the past couple of weeks, you may have been frustrated that these were gone, but they're back now. We have a new thing called theater mode. that kind of pops this all out into a bigger view. So a bunch of new ways to sort of use that sketchy video. But now we also have these content cards. And again, you saw this funny blobby baby when they're just sort of like lying there not doing. I have a 3-month-old, so I'm very familiar with this phase right now. Lying there not doing much, maybe starting to lift their heads or unclenching their tiny baby fists. We tie this sort of text information back to the video. If you watch the video, you'll sort of understand all these various symbols. And so we use these text cards again as a way to move quickly and sort of more modularly through the content. So, okay, I got to 6 months. Now my resident asked me to go send labs or go see a patient or whatever it is. Like, I stop here, and when I come back, I'm right at this place again. Like I said, we're trying to make Lisa famous. So Lisa has built us this awesome set of clinical pearls that are sort of the things you just learn from experience or that you can't get out of a textbook. And so we've dropped these throughout the Peds course, again, to help you get in that sort of clinical thinking mindset, not just sort of the preclinical, like memorize and regurgitate.
I'm not sure how I feel about having my face in this many places quite yet, but I'm trying to get used to it.
So, we take you through the lesson. Depending on what the topic of the lesson is, obviously the structure may differ. So maybe instead of 4, 6, 12 months, the way that it's set up, instead it's how do they present? What's the physical exam? What diagnostics are you going to order? What's the management? Just depends on what the particular topic of the lesson is. Somebody, I think in the chat, mentioned the cram cards. So this is our attempt to distill this information down into just one single place where you can go and say, I'm about to walk into my test, or I'm about to walk into a patient room. What is the information that I absolutely must know? The information that if I miss the question on the test, I'm going to be kicking myself, right? The high yield of the high yield, as it were. And then we have the lesson quiz questions. Again, if you're using lessons that had these before, they're the same ones, but we have these throughout at this point. And that's the lesson. And then, you move on to the next one. These are meant to be, again, something that you get through quickly and efficiently and in a way that's easy to pick up and put down. There are tons of these. I'm not going to walk through all of them, but that's the new Sketchy. Stop my share there, but I see a lot in the chat, and so maybe we can answer some quick questions about that before we move on to Connor's section. Somebody asked about Android app. Not yet, unfortunately. We are a small team, and so we have to focus on what we can. So no Android app yet, but we do have the iOS app coming this summer. Somebody asked, it looks like some of the new lessons don't include videos. Is this correct? That is correct. So not every lesson has a video associated with it. Some are just cards. We tried to do that based on what we thought was that there's an implicit sort of importance designation based on that. So if we think something's really important, it tends to have a video. If we think it's a little bit less important, it's less likely to have a video, but also just what makes sense as sort of the memory palace approach versus what is something that is easier to just sort of read through or look through. One thing that you didn't see in that example, just because it doesn't apply as much to that topic, is the use of clinical images like x-rays or anatomy or things like that. We have a lot of those in there too now that we think are super helpful, especially for clinical students. Thank you, Joseph Kelly. Yeah, these are just as helpful. We love to hear it. Let me see if there's any other questions in the Q&A about this. Looks like not right now. Actually, here, I'll take this. What's your process for updating information in the videos, such as when guidelines change or there are new drugs? How does that happen? How long does it take? That's one thing that we love about this new platform is videos are just harder to update. Whereas with the cards, it's super easy to, if a guideline changes or a recommendation changes or an indication for a drug changes, right? We've all heard about Ozempic and the new weight loss drugs. We can add that information in pretty quickly without having to remake a whole video. So how does that happen? You know, we're constantly paying attention to this stuff. We've got multiple doctors on the team working on this, but there's also, and maybe you saw this while I was skimming through this quickly, there's a little thumbs up, thumbs down button on every card. And so if you see something that you think is wrong, hit the thumbs down. It'll ask you for a little explanation. And we read every single, like, thumbs is something that I look at every morning when I wake up and every night before I go to sleep. You know, what are people saying about the lessons? Are they finding errors? We try and get those fixed as quickly as we can. Will Sketchy incorporate a spaced repetition memorization system soon, like Anki? And I think somebody else asked a question about Anki as well. Great question, Tara. Email me, ben@sketchy.com. I'd love to talk more about that. Awesome. Will there be a section for emergency medicine added later on? Another great question. We wanted to start with the 7 required rotations because they're common across every med school. For instance, I did not have a required emergency medicine rotation because I went to a school that didn't have a real ED, no offense. So I think those kinds of additional clearly there's tons of stuff that we could focus on outside of the 7. And again, I think this is a place where the new platform potentially enables us to add in smaller packages of lessons or things that might apply to emergency or other sort of subs. I did urology. You know, we do a little bit of that, but there's not a urology course. So I don't want to promise anything. There's no EM course planned right now, but all of that is stuff that is on our minds very much. All right. Happy to answer more questions about that as we go, but Jen, maybe we can hear from Connor. Hey, Jen, we can't hear the audio. I think you need to share your computer audio. Let me take a few more questions while Jen figures this out. When will the new app be released? Later in the summer. I don't want to put a specific date on it because, like I said, it's not entirely up to us. Apple needs to approve it. So sometime, hopefully in the next month or so, but no promises. When is the AI-enabled case-based learning tool releasing? Somebody's got insider information. Valentina, you'll have to tell me your sources. Again, I don't want to make any promises, but that is something we're working on. So coming later in the future. Let's see what else. What else are people asking?
I think some people had some good questions just about like letters of recommendation and what that looks like on your Eris app or Eras, however you want to say it. I feel like now with the Taylor Swift Eras tour, everybody says it Eris, but Eras is, I guess, technically what we say. But in terms of your letters of rec, we really, of course, want to see like a deep experience with that one person. So at least having some connection with them. I know that can be hard when attending is like you really interact more with like the residents or a chief resident on a team as opposed to the attending. And I will say it's not infrequent that I see when I'm reading applications that like the senior or the chief has submitted feedback about that resident that's incorporated into the letter of recommendation. So I think that is one way around it, that you can just you can ask your senior, whoever you worked with most directly, to give feedback to your attending to give, right into their letter of rec. Trying to see what other, a lot of people just asking for general tips on kind of what to do this cycle as they're applying currently, kind of in the next 2-3 months here. ERAS is opening again, and kind of what things to be putting into your application. And I would just say that things that I look for, as again, I read like thousands of these applications, and I have been doing that for the last like 7 years straight now, that I think in terms of your extracurricular experiences, we really like to see deep experiences. So I don't want like a mile wide and an inch deep of all the things that you've done. If there's just a couple, like again, quality over quantity, if there's a couple that are really meaningful, that is much more impressive than you having done everything, but just like been to a meeting for that group, like one time. So having deep experiences is one, and then just having really robust clinical experiences where I can then look through your evaluations and see that you've been a valuable member of your team and a successful member of your team.
I think given the length of Connor's video, I think what we're going to do is we're going to audible on that. We can share that out with you in an email. But I know there are still a lot of questions, so maybe we can keep answering some of those. I think there was a question for you, Lisa, back up a few that I wanted to ask. If you find electives very expensive and don't do them, and you're still applying to match, what are your chances for getting matched into Peds? I assume that sort of means away rotations or something that costs extra, essentially.
Yeah, for sure. And I just put a typed answer into that. So, it is not at all a necessity that you do an away rotation at the place where you want to go. Like, we realize that not everybody is going to do that. Of course, it's awesome when like, you can use that month as like a 1 month long interview period for that program. But certainly not everybody does that, and it's not necessary. And plenty of people match at places where they have not done away rotation. So I would say doing the away rotation is more for you to like kind of feel out a program. I think I did an away rotation at a place that was close to home for me, so I could like literally go live at home for a month and kind of feel out that program. And that worked out conveniently, but it really kind of depends. The financial situation can be really challenging. So I would say it's not at all a non-starter with coming to a program.
I will say, just for those not applying into Peds or considering other specialties, that answer may differ a little bit depending on what you're going into. So I think for urology, for example, what I did, there is definitely more of an expectation that you do, not even in a way necessarily where you want to match, but just that you have spread your wings a little bit. And it is unfortunately like punishingly expensive. I actually also did one close to home so that I could live at home during that period. But I also did one very much not close to home, and I just like had to pay double rent from it. It was terrible.
Yeah.
So yeah,
and I think you'll definitely see that in programs that are smaller, right? Like if urology is only taking 5 residents that year, as opposed to like when I was at UCLA, right? We were taking 30 residents a year. Like we can't have all 30 of the residents we choose have done an away rotation at UCLA. So yeah, I think definitely the smaller programs want a little more intimacy in that way and time with you.
I'm sorry if I missed you answering this before, Lisa, but we have a couple of questions about letters of recommendation for IMGs. I don't know if you touched on that already.
Yeah, I think when it comes to IMGs, I don't think it's any different per se than the letters that I'm looking for a US grad. I do, again, I know I keep repeating myself on this, but we do really look for your clinical skills in that. So I'm kind of deciphering as I read through these letters, whether you're IMG or not, like how involved were you on your team? How successful were you on your team? We love it when like letter writer is able to give us specific examples of like a case you might have worked on and how you were involved with it. But really having that reflected in your letters that like, oh, this is somebody that I worked with on the wards, in the clinic, those kind of things. I think it can work where you have that in combination, right? You have like 3 or 4 letters. If you worked in a bench research and were in a lab for 5 years before you went to medical school or something, it's total, or before you went to apply to residency, that's totally fine to include that as one of your letters because it shows kind of the breadth of your application. But we still do, like, we are training physicians, so we still do want that kind of clinical relevance anytime I'm looking at a letter.
Awesome.
I think there's 2 questions about step 1 failures.
Yeah.
So I will say, again, this is in pediatrics specifically, that a step 1 failure or a step 2 failure is not, I would say, is not as huge of a red flag as I think some people feel it is. We definitely like to see an explanation for the failure. So if you just have a failure listed and then you pass the next time or whatever it ends up being, it is a little harder to interpret. I think that we do like to see an explanation somewhere. Some people put that in kind of like their, I forget what the section is called now, but there's like a little important like explanation thing. You can put it in there, or some people incorporate it into their personal statement. I love that my dog is flashing in and out of my thing now. He's like laying on the couch behind me. So that's part of it. And then we, of course, also want to see that you have gotten a robust score after having failed. And then, of course, again, just making sure the rest of your application is very well-rounded. Like if it's kind of weak on the clinicals or weak on the extracurriculars and you had a step 1 failure, that's a lot more challenging for us than it is to be like, okay, they had 1 step 1 failure, they explained it, they were going through a difficult time, didn't, hadn't learned how to like study appropriately, then had a robust score after that, and they have a really well-rounded application. Like there's no reason we're not going to interview you again, especially in pediatrics. I don't know for surgery or something that might be different, but in peds, that's our approach.
I know we only have a couple of minutes left here. Happy to keep answering questions, but I want to make sure we get to our special offer from Jim.
Great, let me share my screen. I'll go back over here. Oh. Let me do the raffle first. But essentially we are giving away a free 6-month Sketchy Medical subscription, and I have everyone's intro poll submissions, and we're going to randomly generate a number, 78. So the winner is Michaela Cochran. I might be mispronouncing that last name, but let me know if you are here in the chat. Michaela, yes.
Yes, got it on the first one.
You are here. Well, thank you. I will reach out to you in regards to your login information, but congratulations. And for the rest of you guys, don't worry, we have a special offer for you all. Anyone who do not have a subscription, or your subscription may have expired, 25% off Sketchy Medical. This is very exclusive just to attendees for today. And so it will expire tomorrow, end of day. So the code is webinar25. I will also send this out in the post-webinar email so you don't lose it, but did want to share this offer with you all. We can take the last 3 minutes to answer one last question, if there are any.
There sure are. Actually, this is an interesting question. So about, it looks like a gap year, but after med school, and how residency programs sort of evaluate that.
Yeah, that's a good question. Gap years, I think, in many ways are make you more interesting. So I think there are plenty of gap year experiences that we have, like, you used it in a valuable way, we're excited by, especially those gap years maybe between undergrad and med school. If there's a gap year or a gap, like a kind of leave of absence type of experience where maybe in the middle of med school you had to take time off, or you had to delay going from med school and applying into residency, we do want to see more of an explanation there for sure. And just showing that you've had like continued engaged clinical experience, either like direct clinical experience, or maybe, something else, I don't know, working for a medical education company or something like that, just something else that showed your continued interest in medicine. But I think that's like when we get into those gap years that are either in the middle of medical school or after med school before applying to residency, we do want to see more of an explanation. And again, not to say that that's a non-starter at all. It's just that we do want to understand why that happened for you. Let's see another question about like how important is research when I'm looking at your applications. I agree. This is totally specialty specific. And Ben, I don't know if you have more experience on the urology or kind of like more surgical side of things. I would say in like Peds, family medicine, internal medicine, kind of the more general specialties, that we do want to see your interest in something like that you kind of followed through with a project or have had some experience in research, whether that is bench research, clinical research, quality improvement research. It can come in so many different forms, but we do like to see that as part of your experiences. Does not have to be like you're super involved, like, a big one. If research is not something that like you want to do with your career, we are not going to like completely fault you for that. So I think just showing some interest there is great. And then if you have other things that you're deeply involved in, like you were running the free clinic for your med school, like we would much rather you then talk about that.
Absolutely. Yeah. I think in urology, research is maybe a bit more expected. And I think even for some other fields like derm or neurosurgery or something like that, perhaps even more so. But I totally agree that I think a genuine interest or commitment to something sort of in the field of medicine that isn't just direct patient care, it is extremely helpful. So whether that's running the free clinic or doing education programs for, earlier students or something like that, I think all of those things are helpful. Sort of by definition, residency programs are part of academic medicine. And so that emphasis on research and on teaching and on clinical care, like that sort of bipartite mission is built into their blood. And so I think that, the clinical part, you've gone through med school, you've sort of demonstrated that through your grades and your step scores and all that. But I think having at least something in one of those other two areas is super helpful.
For sure.
Does research done during undergrad also count? Just to follow up on that, I think to Lisa's point, if it was research you did a long time ago and then you just sort of never followed that thread, that tells one story, versus if it's research that you did during undergrad and that was a passion and you kept sort of building on that during med school, that is an extremely compelling story, I think. So
Yeah.
research that's clearly purely sort of like to check a box, I think is less valuable than research that seems like it's a meaningful part of your interest and experience.
I think most importantly, there's a lot of questions about the Starbucks gift card in the chat, which I believe is now being addressed.
Yeah, just answer that survey with your email and we'll send you some coffee.
I understand how important coffee is, so I get that there's multiple questions about that.
It's funny. I didn't drink coffee all through like med school, residency, never drank coffee.
Oh
Had
my
a
God.
kid, immediately had to start drinking coffee.
Yep, that'll do it for sure.
If someone loves human behavioral sciences as a researcher but wants to do residency in Peds, is that possible?
I'm not sure if I 100% understand the question, but if you love behavioral sciences as a researcher, but you also want to become a clinician, certainly there are specialties in which you can marry those two things, like, I mean, in peds, like developmental pediatrics, it's like developmental and behavioral pediatrics, DBP, is a great fit. And if you have that type of experience, for as an IMG and then coming, but you also have, of course, like clinical experience in medical school, that could be a great complement together to bring to an application. I hope that's answering your question, but yes.
Sorry, I was muted. What about law and policy research? Again, I think if that's your sort of particular area of interest and your passion, absolutely. Like that's 100% worth talking about. Healthcare policy is a pretty important space and will only become increasingly so. I also think, maybe more generally on the question of research, it's specialty dependent, but it's also program dependent. And so once you sort of know what field of medicine you want to go into, you'll talk to sort of your advisors at your school who will help you identify if you're a big research program person, here are the programs that are appropriate for you. If that's not an interest at all, here are programs that might be more appropriate. You want to do sort of health policy or something that's a little more outside the direct patient care experience. Here's a program that might be great for you. That's something that you can flesh out sort of as you go.
For sure. I do see some questions about failing preclinical years, but passing exam scores, like passing your step scores, or sorry, step exams. Failing your preclinical years does raise questions for us when reading, but again, nothing is like a complete non-starter. So if there is, again, we just want to know why and what the context was. So if there was a big life event going on for you, if there was some extenuating circumstance, and you're able to explain that and then show that you improved, that you kind of came through, and it can show resiliency, which we like to see in applicants too, that we are happy to hear that and to consider it.
Tell us more about your team. Pull the curtain back a bit. I'm a Sagittarius. I'm actually not even sure if that's true. We're doctors and fun-loving people, and I think sort of Lisa's contribution here is really an emphasis. Really helps emphasize this. Ultimately, we think and care a lot about the med student experience and how you learn medicine. And I think, even since I went to med school back in my day, I think the way that people consume content has changed, and that things like Sketchy are the sort of ancillary resources have become more and more important and more widely utilized. And so that's a lot of responsibility, honestly, and it's something that we care a ton about. I'm not going to give you our home addresses or anything, but we'll have that be the answer. And then to that point, where's Andrew? He was right here. I'm in a conference room right now, and he was right here with me earlier today. He's working on cool new stuff that Valentina knows all about.
Yeah, that's a fun fact. I went to medical school with some of the creators of Sketchy, and it started, I don't know, our second year of med school, I guess, that they were starting to make some cartoon images for us to help with memorization. And then here we are, many, many, many years later. It's very, very cool.
Yeah, isn't that funny? I think we talked about some of this matching gaps stuff. Step 2 CK with a 268. My goodness, congratulations.
There's my
I would apply with that for sure. Preview of future videos that we're working on. Again, I don't want to get too much into specifics now. I think there's, we've, as I said, updated or added a lot to our clinical program. We're going to keep doing that and working on it over the next several months. Hit those thumbs up, thumbs down buttons. Let us know what you like and don't like. this isn't, I said this before, but this isn't some giant corporate entity. We are a small group of people who read all the feedback, really care about it, pay attention to it, take it into account. Or email us. I think Jin's blasted out my email to YouTube, so I'm going to get all kinds of weird spam. But yeah, seriously, happy to chat more by email. We love to hear from students. It's why we do this. So by all means, reach out. Are there any more questions that we didn't answer in some form or fashion? Thank you all for sticking around a little longer. Really, really appreciate it. Try out the new Sketchy. Let us know what you think. We'd love to hear from you. Yeah, thanks for spending some time with us tonight. And thank you, Lisa, for everything you've put into the product so far, and for coming tonight, and for the future work we're going to put on your plate.
No, I'm so excited. And obviously from like the medical education side of me, being able to contribute like a more clinical lens to everything is really fun. Because I totally see the value in how Sketchy, like the material that Sketchy already has, can completely just segue perfectly into the clinical rotation. So I'm really happy that it's worked out, and it's really exciting.
So,
and thanks for all the good questions.
Yeah. This was a great conversation, in as much as it can be with only our faces showing. All right, now get out of here. You got sleep to get, or studying to do, or I know you've got better places to be. So scram.
Thanks, everyone. I have to literally go to a night shift currently, so I'm heading out now.